Hello, my name is Dr. Emily Nelson Mayer from the Brigham and Women's Hospital. I'm going to demonstrate the proper technique for endotracheal intubation. We'll review the indications, contraindications, equipment, setup, correct technique, and potential complications of this procedure. Indications for endotracheal intubation include impending respiratory failure, inability to protect airway, cardiac arrest, and general anesthesia. There is no absolute contraindication to endotracheal intubation, except if a patient has a do not intubate directive. Relative contraindications include suspected difficult intubation or ventilation, tracheal, facial, or neck injury, tracheal mass. The upper airway consists of nasal and oral cavities, pharynx, larynx, and main bronchi. The vocal folds run in the AP direction from the thyroid cartilage to the arytenoid cartilage. The epiglottis is a flap of elastic cartilage that folds over the vocal cords and protects the airway from food and liquid. Because the right main bronchus is larger in diameter, shorter, and more vertical than the left main bronchus, aspirated materials more commonly go to the right side of the lung. Endobronchial intubations are typically right-sided as well. When intubating, place the Macintosh blade in the space between the base of the tongue and the epiglottis, called the vallecula. Pull the blade up and forward at an angle perpendicular to the patient's mandible to allow placement of an endotracheal tube under direct visualization of the vocal cords. We will now review the specific steps required for endotracheal intubation. Proper identification of factors that predict difficult ventilation and intubation are important to elicit. To determine if a patient will be challenging to ventilate, ask about difficult ventilation in the past, snoring or obstructive sleep apnea, airway masses or tumors. Several physical exam findings may predict if a patient will be challenging to ventilate. Age over 55, facial hair, lack of teeth, obesity, thick neck or abnormal neck anatomy. Patients who are difficult to ventilate are at increased risk of being difficult to intubate. Many of the history and physical exam elements that predict difficult intubation are different from those relevant to ventilation, though equally important. To determine if a patient will be challenging to intubate, ask about history of difficult intubation, history of obstructive sleep apnea, history of C-spine injury, pain, or decreased range of motion, history of facial or neck trauma or surgery, history of facial, neck, or mediastinal mass, history of neck radiation, temporomandibular joint disorder, history of obstructive symptoms such as snoring, difficulty swallowing, hoarseness, stridor, or difficulty breathing when lying flat. Several physical exam findings may predict if a patient will be challenging to intubate. Mallampati score, mouth opening, neck extension, thyromental distance, abnormal mandibular protrusion, age over 55 years, and obesity. The Mallampati score is a classification used to predict difficult intubation. When assessing the Mallampati score, the practitioner asks the patient to open his mouth and protrude his tongue. The score is based on the oral anatomy seen. A Mallampati 1 score is given when all of the uvula, soft palate, and pillars are visualized. Mallampati 2 when the soft palate and part of the uvula are visualized. Mallampati 3 when only soft palate and the base of the uvula are visualized. And a Mallampati 4 score is given when only hard palate is seen. Mallampati 4 scores are associated with a higher risk of difficult intubation. Thyromental distance is defined as the distance between the mentum and the thyroid notch when the patient's neck is fully extended. Thyromental distance of less than 3 finger breadths or less than 6 centimeters in an adult predicts a higher rate of difficulty in lining up the laryngeal and pharyngeal axes for successful direct laryngoscopy. It is important to have all the necessary equipment at hand before attempting an intubation. For an uncomplicated airway, the basic equipment needed includes non-sterile gloves, protective eyewear, free-flowing IV for giving induction and emergency drugs, induction, paralytic, and emergency drugs, suction for removing secretions and/or blood, standard ASA monitors including EKG, pulse oximeter, and non-invasive blood pressure cuff, reliable high-pressure oxygen source, ambu bag for ventilation, face mask for ventilation prior to intubation, oral airway for ventilation, endotracheal tubes, one size smaller and one size larger than presumed size, syringe for cuff testing and inflation, laryngoscope handles, laryngoscope blades, a curved Macintosh and a straight Miller in various sizes, in-tidal CO2 detector, stethoscope, tie or tape for securing the tube, LMA in case of inability to ventilate or intubate, one size smaller and one size larger than presumed size, stylet. The stylet should be inserted in the endotracheal tube and bent into a hockey stick shape to facilitate passing the tube through the vocal cords. In addition, it is important to ensure the stylet does not protrude past the end of the endotracheal tube in order to prevent tracheal injury. Proper positioning of the patient is critical to successful intubation. The patient's bed should be adjusted so the height of the patient's airway is at the level of the provider's xiphoid cartilage. Place the patient in the sniff position to help create a line of sight from the eye of the provider to the larynx so that the oral opening and the pharyngeal axis overlaps. This can be achieved by placing a blanket under the head to elevate the occiput approximately 10 centimeters, thereby flexing the neck, and by extension of the atlanto-occipital joint. A wedge-shaped pillow is useful to achieve the sniff position in morbidly obese patients. Before administering medications to induce anesthesia, ensure that you have optimal intubation conditions on the first attempt at laryngoscopy. It is important to optimize patient position, check all equipment, check access, and pre-oxygenate the patient prior to inducing. Pre-oxygenation with 100% inspired oxygen replaces the nitrogen in a patient's lungs, which increases the time that a patient can remain apneic without desaturating. Perform pre-oxygenation by using high-flow 100% oxygen. Have a tight mask fit to prevent the entrance of room air, and allow the patient to breathe spontaneously against an open pressure relief valve for 3 minutes or 4 vital capacity breaths before inducing anesthesia. Pre-oxygenation is adequate when end-tidal oxygen approaches 85 to 90%. Prior to attempting endotracheal intubation, any practitioner should be adept at mask ventilation, the most important airway management skill. If you can successfully mask ventilate a patient, then you can maintain ventilation and oxygenation until a more experienced airway provider is available to perform endotracheal intubation. If your patient is conscious, you need to administer an induction agent before attempting mask ventilation and intubation. For proper mask ventilation technique, allow the left thumb to rest above the connector and the index finger below the connector on the mask. Apply the tip of the teardrop-shaped mask to the nasal bridge. Firmly hold the left mandible with the third and fourth fingers of the left hand. The inferior rim of the mask should rest between the patient's lower lip and chin. Place the fifth finger behind the mandible and use the third to fifth fingers to pull the patient's face up to the mask, rather than pushing the mask down to the patient's face. This technique of lifting the patient's face up to the mask helps elevate the laryngeal structures and soft tissue to create an open passage for oxygen to move from the mouth to the larynx. Adjust the pressure relief valve and squeeze the bag in order to ventilate the patient, with the goal of keeping peak airway pressures less than 20 to 25 millimeters mercury. The pressure relief valve should be partially closed in order to create enough pressure in the system for mask ventilation. Assess the adequacy of mask ventilation by chest rise, breath sounds, tidal volumes, and capnography. If you are unable to ventilate, it is important to immediately call for help and to prepare for insertion of a laryngeal mask airway, or LMA. The goal of direct laryngoscopy is to visualize the vocal cords in order to pass the endotracheal tube through the cords without causing trauma. After an induction agent has been administered and adequacy of mask ventilation has been determined, administration of a paralytic agent, such as succinylcholine, is useful for optimal visualization of the vocal cords. Remember these important contraindications to succinylcholine: family or personal history of malignant hyperthermia, hyperkalemia, burn injury, crush injury, upper motor neuron lesion, prolonged immobilization, myopathy, closed head injury, open globe injury. Use your right hand to scissor the mouth open. Place your right thumb in the bottom right corner of the patient's mouth on the back lower molars. Place your right index finger in the upper right corner of the mouth on the back upper molars. These fingers should be extended to maximally open the mouth. Grip the laryngoscope with the left hand where the base of the blade intersects the handle, with your thumb facing up on the handle. When inserting a Macintosh or curved blade, place the laryngoscope in the right side of the patient's mouth and sweep the tongue to the left. Do not rock your wrist back when the blade is in the mouth, as this may injure the patient's teeth. Instead, once the laryngoscope is in the mouth, pull up and forward at an angle perpendicular to the patient's mandible. The goal is to place the curved blade in the vallecula, the depression between the epiglottis and the tongue, and if it is in the correct position, you will see two white vocal cords under the tip of the pink curved epiglottis. If the cords are not visible, the laryngoscope may need to be inserted more deeply or pulled back slowly to a more shallow location. Sufficient force perpendicular to the patient's mandible is necessary for cord visualization, but remember that bending the wrist and using it like a lever will not improve visualization, but instead will put the patient at risk for dental injury. In addition, check to ensure the patient's lip is not between his or her teeth and the laryngoscope to avoid lip lacerations. The straight blade is useful in patients with an anterior larynx or a floppy epiglottis, as is typical of young children. When using a Miller or straight blade, insert the laryngoscope in the right side of the patient's mouth and sweep the tongue to the left. Advance the laryngoscope past the tip of the epiglottis and pull up and forward at an angle perpendicular to the patient's mandible. The Miller blade should be placed posterior to the epiglottis and used to pull the epiglottis out of the way. Therefore, only vocal cords should be visible. The Miller blade should be placed between the cords and the epiglottis rather than between the vallecula and the epiglottis, as with the Macintosh blade. Once the vocal cords are visualized, the styleted endotracheal tube is passed through the vocal cords. It is important to remove the stylet once the tube is through the cords. If the rigid stylet is advanced too far, it can cause injury to the trachea. Once the stylet is removed, the endotracheal tube cuff is inflated with the minimal amount of air needed to prevent a leak when using positive pressure ventilation. Practitioners will obtain different views of the cords based on their skill level in laryngoscopy and the patient's own anatomy. A grade 1 view of the cords is when the practitioner can visualize the entire glottic opening, including all of the cords. A grade 2 view is visualization of the posterior aspect of the glottic opening, including the arytenoids. A grade 3 view is visualization of the tip of the epiglottis only. And a grade 4 view is visualization of only soft palate, signifying a potentially difficult intubation. If the view of the cords is still suboptimal, troubleshooting is necessary. Often burp or backwards, upwards, rightwards pressure can be applied by the practitioner to the trachea to improve the view. In addition, if the practitioner is able to see a grade 2 or 3 view, but unable to pass the endotracheal tube, use of an Eschmann stylet or a bougie, which is a long plastic stylet with its end curved anteriorly, may be considered. If the cords are not well visualized, it is important to mask ventilate the patient while calling for help and thinking of alternative devices to use. You should not repeatedly try direct laryngoscopy, as this can cause cord trauma and edema. Alternative strategies, including placement of a laryngeal mask airway, intubation with a fiber optic bronchoscope, or emergency cricothyroidectomy, will not be covered in this video. To confirm that the endotracheal tube is in the trachea and not the esophagus, check for condensation in the tube, chest rise, breath sounds, and end-tidal CO2. In addition, one should confirm the breath sounds are equal bilaterally, as absent or diminished breath sounds on the left side can signal a right mainstem intubation. After successful endotracheal intubation, it is important to use tape or a tube tie to secure the airway. You should note the depth of the endotracheal tube at the teeth when breath sounds are heard bilaterally. Therefore, if the tube gets pushed into or pulled out of the trachea, you will be aware and can re-secure the tube at the correct depth. It is also important to adequately sedate a patient once intubated to ensure patient comfort and that the endotracheal tube does not become dislodged. There are many significant potential complications associated with endotracheal intubation. These include malpositioning of the endotracheal tube, such as an esophageal or mainstem intubation, airway trauma, such as lip or tongue laceration, retropharyngeal dissection, chipped tooth, sore throat, airway edema, vocal cord paralysis, tracheal injury, or bronchial injury, exaggerated sympathetic response to intubation leading to hypertension, tachycardia, and increased intracranial or intraocular pressure, exaggerated airway reflexes during intubation, such as bronchospasm or laryngospasm, depressed airway reflexes during intubation leading to aspiration, hemodynamic compromise secondary to hypnotic agents, and finally, failed ventilation or intubation leading to hypoxia or hypercarbia. To review, critical steps for endotracheal intubation are the following. Elicit key features of the history and physical that may predict difficult ventilation or intubation. Assemble equipment. Position patient properly. Pre-oxygenate with 100% inspired oxygen. In conscious patients, administer an induction and paralytic agent. Position the tip of the curved blade in the vallecula to visualize the vocal cords under the tip of the epiglottis. Once the vocal cords are visualized, the styleted endotracheal tube is passed through the vocal cords and the cuff is inflated. Confirm proper position of the endotracheal tube. And once proper position is confirmed, secure the endotracheal tube. Bag ventilate any patient who is difficult to intubate and immediately call for help. Thank you for watching this Harrison's procedural video.